Thoracic outlet syndrome refers to a constellation of symptoms due to abnormal compressions of the structures of the thoracic inlet as they pass from the thorax to the axilla in the cervical axillary canal. The various symptoms are related to the structures affected, including the brachial plexus, subclavian vein, and subclavian artery. Abnormal compression can be due to the surrounding muscles or abnormal bony structures, such as cervical ribs. In order to understand the pathophysiology, it is critical to know the anatomy of the thoracic inlet. The cervical axillary canal is bounded inferiorly by the first rib, superiorly by the clavicle, anterior-medially by the costoclavicular ligament, and posterior-laterally by the middle scalene. The anterior scalene muscle divides the costoclavicular space into two compartments, an anterior medial and a posterior lateral compartment, also known as the scalene triangle. Moving anterior to posterior, the subclavian vein is the first structure encountered. Just posterior to the vein is the anterior scalene muscle with the phrenic nerve running along top. Within the scalene triangle is the subclavian artery, followed by the brachial plexus. The middle scalene is the most posterior structure in the posterior border of the scalene triangle. The signs and symptoms depend on whether the nerves, blood vessels, or both are involved in the abnormal compression. Neurogenic is the most common and often presents with limb pain, numbness, or weakness. Physical exam focuses on provocative maneuvers, such as the Addison test, costoclavicular maneuver, and hyperabduction maneuver. Treatment is usually conservative, however surgical resection of the first rib or other abnormalities may be needed. This can be done via a transaxillary or a supraclavicular approach. Vascular thoracic outlet syndrome can be divided into venous and arterial disease. Venous disease, also known as Paget-Schroeder disease or effort-induced thrombosis, results in thrombosis of the subclavian vein due to repetitive trauma and compression. This is seen in patients who frequently use their upper bodies and dominant arm for work. Some examples include baseball players, particularly pitchers, and basketball players. These patients can present with edema, discoloration of the arm, and distension of superficial veins. In acute settings, these patients require catheter-directed thrombolysis followed by surgical decompression of the neurovascular compressive elements.